Welcome to our first spring Free Friday webinar. We're being joined by Zach, I apologize, Ludwig from Bradford Health System Services. I can't talk today. And he is going to speak to us about fentanyl, a huge problem that we all know is really wreaking havoc on the country. And Bradford Health Services is also our sponsor for today. So they even made this possible. If everybody can just be sure to sign in chat. I see a lot of you have already gotten a jump on that. So thank you. If you have any questions while Zach is presenting, I will ask you to please use the raise your hand feature. So that way we don't get people speaking over one another. If you're unfamiliar, if you click the reaction button on the bottom of your screen, it will bring a box up, and one of the things that it'll say is raise your hand, and that will alert both myself and Zach to the fact that we have somebody who would like to ask a question. And with that, I'm going to turn the reins over to Zach and let him get started. Zach, take it away.
Thank you very much, Julie. Nice to see everybody. I got the opportunity to do a few of these sessions with you all last year in the summer and fall, and that was a great joy. So I'm happy to be back to pick that back up. So today we're certainly going to be talking about fentanyl, and I want to give you some information. I may have given some of this before in some of the previous sessions. I'm going to be giving some updates as some things have changed, and some latest statistics and all of those great things. I only have an hour. I'm going to do my very best to move through these slides. As Julie said, you want to ask a question, raise your hand. I'm also watching the chat, so feel free to chat me. I'm usually pretty good about multitasking and seeing a question and answering it. I see Jeanette has raised her hand. Jeanette, you want to unmute yourself and ask a question?
Yeah, I just want to ask, is there any way to stop the chat from flashing on the screen in front of the slides?
Oh, is it?
Every
Can you
time
see
somebody puts something in the chat?
Can you see the chat? Okay.
Yeah.
Okay. All right. I was not aware you could see that. Usually in my experience, you can't see my chat. So you can see that?
I think what she's talking about is sometimes a box will pop up on your end that then shows up as just a black box for the attendees. I think is what she's talking about.
Yeah, is there some way to disable that from popping up? Because it's
turned it
very
off
distracting.
now. So do you see it now?
Yeah.
No.
Okay. Well, then I can't use chat.
Well, no, Jeanette, you can see it right now. It's up on your screen?
I can see it. It's people keep.
Is that your chat?
And every time somebody chats, it pops up on the screen.
She probably needs to change her view. So right now, the way she's seeing is the screen and the chat. But if you look in the right up-hand corner, there's a view. You can click that link and change the way that you see the presentation.
No, that it's changed to full screen. So it is on full screen, but the chat keeps popping up nonetheless.
Have you tried just closing your chat?
It is closed.
Okay.
If you go to more, and you can turn off show chat previews, and that will take that box away.
Where is that? I'm sorry.
3 dots at the bottom that say more. If you click on that, you'll see something that says show chat previews. And if you deselect that, so the check box goes away, it'll make that box go away.
Okay, well, I'll figure it out. Thank you. I apologize for wasting time on this.
Just worry. So Julie, are you seeing the chat that I have on my screen? Do you see the slides in full without any hindrances?
I do.
Okay, I'm going to proceed. Thanks for bringing that to attention, Jeanette. So let me first tell you about Bradford really quick. Bradford is a long-term treatment provider here in the Southeast. We operate in 5 states: Alabama, Arkansas, Mississippi, North Carolina, and Tennessee. We offer residential as well as outpatient treatment in those states. We offer free 24-hour consultation services for anyone. I'll give you our phone number towards the end for how you can reach us and share those with the folks that you work with. So if anybody is interested in understanding if they would benefit from treatment, we offer those calls, as I said, available 24/7, and we can help with placement. So I'm going to be talking about fentanyl, as I said. We're going to be going over some information from before, but with some updates again. I am a licensed counselor. I'm licensed in Alabama, Tennessee, and Florida. I've been with Bradford since 2011, working as a primary service provider with adults and adolescents. Since 2016, I've been working at our corporate location in Birmingham, Alabama. I've held a few different roles during that time, but right now my title is Vice President of Clinical Services and Accreditation. So I oversee our clinical product and our counselors and social workers across all of our sites. With the accreditation, I'm very cognizant of our Joint Commission and CARP accreditations and our state licensing. So making sure that we're meeting all of the best practices and standards that are required of quality service providers. So with talking about fentanyl, we're also going to be talking about what we do about it. And one of the things we do about it is a medication intervention. So I will be spending, especially towards the latter part of the presentation this morning, talking about MAT, though I'm going to try not to use that terminology because even that terminology is a bit old hat. MOUD is the accepted proper terminology now. It is medication for opioid use disorder. You've been working in the field for a while. You've also probably heard the term replacement therapy. That's even older than MAT. So always trying to be aware of the terminology as it relates to stigmatization and access. MOUD being more widespread accepted and reducing that stigma. So in case you have been living under a rock for the last number of many years and haven't listened to any news or presentations, we have a major overdose problem, and we have for quite a very long time, and it seems to only be getting worse. You'll see that this slide goes through 2021. In a couple of slides, I'll give you what we know for our provisional data for 2022. And I know that seems like so long ago sitting here in 2024, but 2023 was just a few days ago, and if you know anything about data, especially data that comes out of the government, it takes a little while to get it. So what we know from this slide, and we'll continue to see that in the upcoming slides, is opioids are a major driver in our overdose death rates, but all drug-related and alcohol-related deaths are increasing, and I'll specifically talk about what that means for some of our co-occurring conditions, or what happens when we have these adulterated drug supplies, where we're having so many people now who are succumbing to opioid overdose who never even thought that they were using an opioid. It was never their intention to use opioids. They might have thought that they were using, let's say, Xanax or methamphetamine or another illicit substance. But they are being exposed to opioids, and primarily in the case we're talking about, fentanyl. So overdoses really kicking off 2013 for our latest wave of this epidemic, but magnified during COVID. And so lots of presentations, lots of attention with what was happening during COVID, where we saw some shifts. We were seeing higher rates among men. That's usually always been the case. But we also saw a correlation with those who were recently unemployed, which doubled compared to where it had been the year prior to the emergence of the COVID pandemic. And then those, of course, with mental health conditions and other co-occurring conditions, that doesn't change very much. What was really noteworthy, and it's really a driver because of COVID, was people dying in isolation because hospitals were on diversion due to COVID, or people were unavailable to access emergency services for whatever reason. So that continued, and you know, to a degree, that's still very much a reality today. We'll talk about overdose reversal and some of the things that we can do and what we need to be aware of as citizens of the world. So this is that updated provisional data. So as we're seeing here, more than 100,000 people confirmed dead of drug-related overdoses in the year 2021. What the data for 2022 is showing us so far is a pretty mixed bag, and depending on exactly how you read it or what your source is, we're expecting either a 2% increase or possibly a 0.5, excuse me, a 2% decrease or possibly a 0.5 increase. That's not much of a variance in range. So really what we're going to talk about is we got 105,000 to 110,000 people die in the last year, 2022, due to overdose. So even in the most rosy terms where there might have been a slight reduction, it is ever so slight, and it is not the same in every state. Some states experienced a significant increase, whereas some had a decrease or stabilization. When you break down some comparisons about the buckets, the different kinds of substances, nearly everything is going up except what we see among the prescriptions. When I say prescription, I usually am talking about something like a hydrocodone, Percocet, something like that. Reasons why those have been relatively stable over the last number of years is because prescription practices have changed a lot. There's been increased regulation over the last decade, really, for prescription drug monitoring programs that are rolled out in many states, though I will say it is not mandatory in all states in the United States. There are still a few holdouts that do not utilize these programs. Fentanyl going up significantly, and then you'll notice that I've included here psychostimulants. Usually what I mean by that is methamphetamine as well as cocaine. Those are increasing. So we're seeing people who are overdosing on those substances solely, but really what these numbers are telling us is the concurrent use of fentanyl that are mixed into these drugs, again, often at unknowing to the user. So that's a very dangerous position to be in, and we'll talk about some of why that exists and some of the societal cultural reasons why we're seeing this. So point of these slides, the takeaway is it's not getting any better. And depending on what area you tend to focus in, it could be getting worse. These fentanyl use, these truly synthetic opioids are really the main driver, as I said, since 2013. In 2013, as noted in this slide, is our latest wave in the opioid pandemic. Pandemic going back really to turn of the century when we were talking about the prescriptions. So as I said, those have been getting more under control so that we have less diversion of those. Then we see the heroin rise as that supply was being restricted. People turned to the streets for heroin, and then what happens with the heroin and other opioids is the cartels got more creative about how the supply chain works, and I'll speak more to that in just a second. But let's go back again, one more tick. Let's really start back in 1999. If you've not watched this show, I encourage it for everybody. It's called Dope Sick. It's on Hulu. There are a number of other programs that are out now talking about what was going on with prescribing with Purdue and a few things that focus specifically on the Sackler family. And I think that's just a really interesting area to watch. So Dope Sick is a good program because it really shows a lot of different sides, including the experience of the prescribers as well as the patients who were so affected by it. If you don't know, OxyContin hit the market. It was marketed with aggressive misconception of sales techniques, and it was told to be a safe opioid option. Of course, it was not. There's no such thing as a safe opioid, period. That plus some things that were happening in the healthcare system, such as the Joint Commission changing the fifth vital sign to be pain, so that doctors felt an overwhelming pressure to treat whatever pain the patient said they had, which pain can be a very subjective thing. And if they did not treat the pain, they were in fear that they would be sued, lose their medical license, and all of those things. So basically what happened is doctors had a pressure from patients as well as from places like the Joint Commission and the American Medical Association to prescribe more. And that's what happened. More and more drugs hit the street. And that's where these things like pill mills started coming, and certain states had more of them than others, certainly. But people lined up around the block with prescriptions, legit prescriptions, that then they would take the medication and either use it themselves or divert it for the resale to others. Now, optimistically, as I've alluded to, we are seeing a reduction over the last really decade of opioid prescriptions nationally. I call out here Alabama in particular, that had a significant reduction of about 38% since 2011. That's good to hear, because Alabama was one of the largest per capita prescribers of opioids in the entire country. It continues to be a pretty high prescriber of all of our states. Takeaway here is, even with reductions, the United States is more medicated than any other developed country in the world. And especially with things like opioids and benzodiazepines, we have greater degrees of access. So more medicated population means we have more of these that are available. So diversion is very possible. Not so possible. It's happening constantly. Um, but also just more and more people who are being exposed to these medications, which, I'm not a doctor, as I said, I'm a counselor, but these are not intended to be long-term pain management plans for 99% of people. But that is the way that many doctors continue to prescribe this. If you've had any surgeries in your life, as I have had, I got pretty high supplies of controlled substances. I did not need them. Most of the research says you're supposed to take these for about 2 days and then move to something like non-steroidal anti-inflammatory, ibuprofen, something like that. But that's not the way that most people are prescribing or using these substances. So lots of pills were out there. And then, as I said, second wave, where opportunistic criminal elements, as supply chains were drying up and people couldn't get their legitimate prescription pain medications, you saw the emergence of more things like heroin. Many people, in some data saying up to about 80% of heroin users made that transition from prescription pain medications to heroin because of supply and cost. So where there is a demand, there will always be a supply. Business teaches us this, and drug and alcohol are no different. This continues to happen. We see lots of crackdowns, though the cartels are very resourceful and creative. So now what they do is they say we can take other type of opioids, including things like fentanyl, and we can make that the primary product that we're selling. And why would they really do that? Well, it really comes down to supply chains. If I have to traffic a kilo of opioid across the border and then cut it up and sell it on the street, it's a lot more profitable to move a more potent opioid, in this case fentanyl, because it packs a greater punch. Fentanyl is about 100 times stronger than the morphine equivalent, which means it's about 50 times more potent than most street level heroin. So it's really just a idea of hiding smaller things is easier than hiding big ones. And what is fentanyl? So fentanyl is a synthetic opioid that is it's a very useful medication. I don't want to demonize all medication. Certain patients need fentanyl with very, very severe pain, especially for end of life care. When we're talking about people who are getting access to things like fentanyl patches. Fentanyl patches are a marvelous creation, and the World Health Organization has said it's a very safe, because it's a transdermal. It's a patch you put on your skin, and it releases the medication. It's a very safe manner of delivering medication to patients who need it. Usually when we're talking about fentanyl, we're not talking about the fentanyl that someone is getting prescribed to them or delivered to them in a hospital or managed care setting. We're talking about fentanyl that's created in clandestine labs, either in Mexico or more often in China, that gets trafficked in. This is not your Walgreens available fentanyl. So anyway, it is an FDA-approved medication for severe pain relief. It is the most potent opioid that is available for human medical treatment. As I said, 50 to 100 times more potent than morphine. It is for those who are opioid naive, as in they do not have a tolerance to opioids. It can be extremely dangerous. Because even a very small amount, as small as 0.25 milligrams, can be fatal for those without a tolerance. It is an opioid, so it activates on mu and kappa receptors in our bodies, and so it's as with any opioid, it operates on the same mechanism, so it works the same way as medicated morphine or heroin you buy off the street. As I said, often being laced more and more within heroin and other opioids and other products, as I've mentioned, and pretty easily to produce if you are smart enough and have a chemistry background, which I don't. I'm not a doctor. Fentanyl, what it looks like, I'm not going to necessarily read all of these, but we're talking about because it has the pain relieving and analgesic effects. Somebody's going to feel relaxation, a euphoria, very positive feeling. A lightness almost is described. You talk to some former people who have used the substance, they describe it as a warm hug, a very fulfilling, enriching experience. There's a reason why the draw of this substance is so high. Now, overdose, what it looks like is stupor. You'll notice a change in pupil size. We're talking about pinpoint pupils with this medication. Clammy skin cyanosis, which means turning blue, a bluish tint to extremities, and in extreme conditions, faces and entire bodies. Coma, respiratory failure that could lead to death. Now, if you're looking for kind of the symptomology among people walking around, usually the stupor and the pupils and the slower breathing, those are the things that are going to suggest the intoxication of the substance. Take all suspected opioid intoxications very seriously. As what we can do is we can offer opioid reversal, and I'll speak to that a little bit more. If you suspect it, go ahead and administer the overdose reversal, because in the case of naloxone, if you're mistaken, no harm, no foul. There will be no adverse response to somebody getting administered naloxone. Carfentanil, which also gets a lot of talk, is even more potent than fentanyl. This is not for medical use, so this is not an FDA-approved medication. We're talking about this as being used for large animals in veterinary medicine. We're talking about hippos and elephants and things like that. So very super potent. It's been identified in 12 states last year, which indicates a bit of a comeback. And I put that in quotes because even though this is, we've been talking about this for a number of years, we actually saw it kind of subside a little bit in recent times. This was really prolific around 2016, 2017. It was a really, really big driver. But then that started being replaced with things like primary fentanyl, which I've already talked about, and xylazine, which I will spend a whole other slide on. Point is, we're seeing more of it. So that says something is shifting a bit in our drug supply potentially. So despite that reduction we had seen, something is going on with carfentanil being out there. Something that gets headlines a lot, and I like to speak about it, is rainbow fentanyl, because this is a great CNN thing. It just gets your attention. It's been really on the scene since summer of 2022 is when you first started hearing about it. If you ask the DEA in their publications, why the colors? Well, they say, well, this is to attract young users and get people hooked and turned on to opioids. I find that to be likely pretty dubious, mainly because if you take an opioid naive person, especially a young person that does not have a tolerance to opioids, and you expose them to this fentanyl, they're likely just going to die, which means you do not have a customer. So I doubt that the drug dealers are doing that. Usually when you think about markings on pills, or colors. It's to create a distinguished product so that people on the street level are saying, hey, I want that stamped one, I want that red one. It creates a little bit of a buzz around your product. You see similar things that they do with MDMA, ecstasy, all kinds of weird stamps on those, which are used mainly as party drugs. So I think that's really what that's all about. But something to be aware of. Xylazine. Xylazine is not an opioid, but I can't talk about opioids right now without talking about this medication. This is a veterinary medicine. Again, lots of things coming to us from veterinary medicine. What they're doing is they're taking drugs, could be anything, but for our discussion, heroin and fentanyl, and they're cutting it with xylazine. Why do they do that? Well, it extends the euphoric effects of the drug you're taking. Problem is, it's not going to be responsive to opioid reversal like naloxone because it's not an opioid. And exposure to this is causing death, intentionally and accidentally. This has been around for a while. 1962, synthesized by Bayer. They did do some human studies, but due to severe hypotension and the central nervous system depressant effects, they did not approve it for human use. We saw a lot of activity last year in the internet threads where people go and get information about how to use drugs, how to source drugs, things like that. Lots more traffic and attention to that. That's what that bar graph or line graph is in the corner of your screen there. That is subreddit activity on a platform called Reddit, where people talk about drugs. So lots of attention. This is also referred to as trank. So you might hear about it like that. It's very sedating when the news shows the clips, and they always use places like Philadelphia or Baltimore, where it's just kind of the walking undead on the street, oftentimes homeless people that are just in that stupor. They're like frozen in space. Some of that's heroin and opioids and fentanyl, and then some of it's this stuff. And this stuff's pretty gnarly. And what happens, especially if you're injecting it, is you can get necrotic, so that you might experience dead tissue that goes to the extent where you might require amputation of limbs. I call it Frankenstein opioids. I didn't make that term. That's what the research actually calls it. These are nitazines. So again, these have been around for a really long time, but I'm hearing more and more about it, especially right now in the northeastern United States. These are getting more and more attention. So again, been around since the 50s as people trying to create new medicines, new painkillers. However, because of a lot of factors like toxicity and sedation, these never took effect the way our current medications are proliferated. So other countries are stepping in. China is increasing its production of these substances, and we have an unknown amount of this stuff circulating in the United States. It's super cheap to produce, even compared to fentanyl and heroin. And it's 40 times stronger than fentanyl. And then it's going to get often intermixed with fentanyl and other opioids and just other drugs, period. The DEA has classified many of these as Schedule 1. The thing is, there's a number of them. It's not like you're tracking one substance or another. So detection of these can be a problem. And speaking of detection, because I know I'm talking to a lot of employers, that's one of the struggles we have as a world right now with a lot of these drugs, where we might either not have drug screens that will detect certain substances, or we just don't have the screens, period. Getting, as an example, CLIA waived drug screens that are approved for detecting fentanyl. As of my last checking, which was not that long ago, there are no CLIA waived drug screens that will give you the dipstick results. You usually have to send these all off to a lab to detect the opioids. And even then, if you don't know exactly which one you're looking for, or if it has one of these Frankenstein opioids in it, it may go undetected. So that creates a lot of challenges in our world, not only for me as a treatment provider, but for you as employers as well. Now, fentanyl, based on our data about overdoses, is extremely deadly, as I said, even in small amounts. You often cannot tell if a drug is laced with fentanyl. So there are some measures that we can take in our world, but it can be controversial at times. So there's a method called drug checking. This would be the drug user taking a small sample of whatever it is that they're intending to take, a powder or scraping off from a pill. And then you mix it with some water and you use a fentanyl drug screen, same one you can buy at Walmart or Amazon. As I said, though, those are not CLIA waived. So some issues with if you want to use these for trying to detect it in urine, but they're out there. So you would check a little bit of that drug to see if it comes back positive for fentanyl or an opioid or whatever it is the drug screen is for. Here's a problem with that. There's a few problems. Number one, it's kind of the chocolate chip cookie phenomenon, which is not my term, but that's what they say. Think about a chocolate chip cookie. If you took a bite, you might not get chocolate chips. And then if you turn the cookie around, you might get all of the chocolate chips all in one bite. And that could happen with the drug supply, especially in the case of pressed pills, where they're taking fentanyl powder and then using a pill press to make it into what could look like a Xanax bar or a Percocet or any other medication. What happens if you took the wrong side as a sample and you think, oh, this is fentanyl clear, there's nothing in it, and then all the fentanyl just happens to be on the other side, and now you're getting a dose of fentanyl you were not prepared for. That is a downside of checking. The other downside of checking is there is a bit of an aversion to do that by users, because we are asking you to sacrifice a little bit of your drug that you're not going to be able to use, or if you do use it, it will be at decreased effectiveness. And they don't necessarily want to give up their drugs, which I can understand. So doesn't always happen. So even with the resource, even with this as a potential option, it doesn't always happen. With fentanyl, because of how the affinity, which is how strong the medication binds to our receptors, naloxone may not work. Naloxone has a very high affinity as well. That's why it has a great ability to push the fentanyl out of our receptors so that the overdose is effectively overridden, stops. However, if there's too much fentanyl in your system, it can reattach and continue to result in the overdose. That's why you often see people needing multiple doses of naloxone in order to be revived. We don't always carry around a great supply of naloxone. For example, I always carry naloxone with me. It's in my backpack, but I have two 2 milligram injectors. If the person I come across that needs this medication has too much fentanyl or other opioids in their system that I cannot keep them revived, and I don't have EMTs on the way, they can go back into respiratory depression and potentially pass away. Now, some people do seek out fentanyl, and I don't want to say that that doesn't make sense. In fact, it makes kind of a great deal of sense if you think about it, because despite what you might be thinking of, like that sounds mad to do so with all of the things you're presenting about how dangerous this is. Well, here's the deal. If you get fentanyl in its purest form, at least you know what you have. And then you, as a user, can make decisions about, okay, I know my tolerance, I can parse this out so that I can do this as safely as possible. The big danger is what we're seeing, as I've talked about. What happens if it has xylazine in it, these other opioid analogs that you're not aware of that are going to complicate that use? So finding pure fentanyl is a novelty. It'd be something that would be looked for with great regard on the street level, but that's just not the way the supply is today, and that's the real danger we're in. And that's why the DEA pushes out things like the One Pill Can Kill campaign right from their website, where they try to educate as many people as possible, including all of you, who I'm speaking to, who can reach those who are at risk. And I say at risk not only as people who may be using drugs and alcohol today, but as far as I'm concerned, as citizens of the world, we're all at risk for this. All pills should be looked at with great question if you do not know the source of them. Now, medications that you're taking now that you're getting from Walgreens and CVS and all those are perfectly safe. There are no indications any source that our legitimate pharmacy supplies are somehow adulterated. It's anything that comes from an alternative source that has to be greatly questioned. So someone put in the chat says it's dropped into cannabis and cocaine, all drugs. We can expect that fentanyl, it can be in all drugs. I've heard some stories about cannabis exposure. Yeah, it's probably happened. It's not happening to the degree that people are making it out to be in the news media. Cocaine, absolutely it is. Cocaine, methamphetamine, those drugs are high risk, and I will actually speak to that in a moment. So thank you. So counterfeit pills are on the rise. That's what I'm talking about. What this shows you, it shows you the real medicine in the top, and then the fake medicine, the pill pressed medicine that looks, if you do not know the difference, it looks identical. So this is, somebody offering you, hey, you're stressed out, why don't you take a Xanax? I have a Xanax here. I'm not encouraging you to do that behavior, but that kind of behavior I know happens all the time. A lot of people get access to drugs from a friend or family member because it's in somebody's medicine cabinet, or they got it from somebody and they think it's this or that. So point is, look at all pills that are coming from an unscrupulous source with a great deal of scrutiny. So these things really started making their waves in 2019, 2020, especially what we saw in COVID, where people were buying all this stuff on the dark web, and even to this day, getting it delivered to your mailboxes. So for those of you who are parents of children, monitor the mail. You never know what's getting sent, and it may not be this, but also getting things like marijuana sent to you in the mail is pretty easy to do too. So watch out for those kinds of things. But that brings us to where we are today with our fourth wave, which is what we're talking about with what was chatted to me just now about cocaine. We are seeing a lot of overdoses with methamphetamine users and cocaine users who do not routinely use opioids, but they're getting exposed to these things because it's being mixed into the drug supply. Methamphetamine and cocaine use disorders are complex to treat, as is all substance use disorders, but methamphetamine is particularly hard. One of the reasons why it's made so difficult is we do not have an FDA-approved medication for methamphetamine use disorder or really any other stimulant use disorder. So that's a tool, like I said, we have with opioid use disorder that just does not exist. So the likelihood that someone relapses with methamphetamine is incredibly high. And so every time they go back out to using and they are potentially exposed to fentanyl and its analogs, is increased risk for relapse. We are living in a world where every recurrence of the condition may be to their demise. That's always been the case, but now more than ever. And that's why we have to be open to harm reduction measures, such as I described already, the drug checking with using those drug screens. And what I want to emphasize about that is that takes the world accepting that, because just until recently, for many states, including where I'm sitting in Alabama, you would get a paraphernalia charge if you had fentanyl drug screens for the purpose of checking your drugs. That legislation was changed last year, but there are still states that will not allow those to be out there. Now, in the grand scheme of things, a paraphernalia charge, when you also in your pocket have an illicit substance, probably not of greatest concern, and probably shouldn't be, but it is just one of those additional stigmatized social deterrents that stops people from accessing harm reduction methods. Where we could go as a society, but it takes a great deal of political will, is safe injection sites, needle exchange programs, opportunities for people to engage with service providers in their areas where they are using, rather than waiting on someone like me who's sitting at a treatment center waiting for them to call me. More efforts to be out there in the space. So as I said, psychostimulants overdose are increasing, often because of the combination there with opioids. There's the data there on the right, and it shows you what the stimulants are by themselves going up, but especially stimulants that are mixed with the opioids, usually fentanyl being the primary leader there. These are some additional statistics about where this is hitting, and this is, all drug use certainly is a uh, equal opportunity offender, and that everyone is at risk, but especially with things like psychostimulants, seeing a great deal of impact in our population of people of color. So the disproportionate number of Black Americans who are being impacted through this, especially during COVID. In some communities during COVID, we actually saw a reduction in some overdoses in some areas. But that was mainly among the white population. And whereas inversely, people of color, their communities were often doubling in some cases in the overdose rates. Someone has chatted about ADHD medications, Adderall, Vyvanse, and things like that. Yes, those are often adulterated. If you are buying those on the street level, those could be fake. They could be counterfeit medications that someone is saying is an Adderall, which is really popular among college kids because it's a stimulant, study drug, et cetera. But yeah, fentanyl being mixed in with those, and that can cause an overdose. There was a story. I know it's not relevant to prescription stimulants, but there was a story, I think it was either last year or the tail end of 2022, of a few West Point cadets who were on spring break, and they decided it'd be fun to use cocaine, and unbeknownst to them, the cocaine had fentanyl in it, and I think at least one of them perished. I think the others were revived on the scene, but that's how this stuff is getting in front of our college age and younger kids. So this brings us a little bit closer to bridging the gap in the time I have together. What can we really do about it? Because we know that most people who need substance use treatment do not get it. And those who do get it are often not getting it from addiction-focused treatment providers. People do go to primary care physicians and others and can get medications and things like that. But it really does take a holistic effort to work with someone who has a substance use disorder. So the more access to a qualified treatment provider, all for the better. So of about 20% of the population that did go to a addiction-focused treatment facility, 31% of opioid use disorder patients and 37% of heroin use disorder patients received MAT or MOUD. That's still not enough. That's 1 in 3 people who need a medication actually getting a medication. And when they get the medications, it's usually for too short a period because there's terms around, hey, you have to be off this medicine by a certain amount of time, or they don't use a sufficient enough dose to be effective to address cravings and overall discomfort. So what often happens is that person leaves treatment prematurely because they're not having their needs met. What some of the data is telling us is that if you have an opiate use disorder and you get medication, you have about a 50-50 shot on whether or not there will be a recidivism in your condition. If you do not get medication, it's about an 80% likelihood that that person will relapse. How this medication works in brief, in brief, is a whole 3 hours, but we have kind of a few different players on the scene. You've probably heard of hopefully all of them, but at least a few of them you've likely heard. We have methadone, buprenorphine, and we have naltrexone. The importance of this image is to show you that the medications act differently in our brains and bodies. Methadone is a full agonist medication, meaning is a full activator. Similarly, if you took heroin and it activates your receptors, which is what causes you to get high, methadone also acts on those exact same receptors and fully activates them. We'll talk about some of those pros and cons in a second. Buprenorphine, as a bit of a difference, it is a partial agonist. It partially activates same receptors. It's the same type of medication. It is still an opioid, but some of the benefits of that partial activation create a ceiling effect, and it also so what that means is if you took more and more of it, there's a certain kind of threshold where you're not going to be as at risk for central nervous system depression. Naltrexone is not an opioid. It is a opioid antagonist, meaning a blocker. So it will sit on those receptors and, as I said, block them. And it has very, very high affinity. So it's really strong bind. So then if somebody then went and took heroin or fentanyl, potentially fentanyl, it will block those receptors so that there is no activation, so that there is no getting high, there is no euphoria. Now, you might have heard that I paused a little bit with the fentanyl. That's because if you took enough with a great deal of potency, you can still die. This is not the absolute savior of you cannot die just because you have naltrexone in your system. It will be a bit of a deterrent because, as I said, you will not get high on that small dose. But it does help with cravings and things like that, but it is not the silver bullet solution. It is a fabulous solution, but it's not the end all be all. When we get somebody on medications, we want to restore normal physiology. We're going to reduce the risk of overdose in a lot of different ways. We want to give people time to work on their rehabilitation, because when they're comfortable and their physiological needs are being met, they can now start focusing on all of the other things that their treatment is going to need, all of the other changes in their life that they're going to need to be working on. Medications, all of them, will reduce the signs and symptoms of the withdrawals, reduce the cravings, and blocking those effects of alcohol and opioids. Naltrexone has a great benefit for alcohol use disorder as well. Let's talk first about buprenorphine, just because it's kind of it's the player that gets a lot of attention, but it's also one where we're having more and more changes that are happening that I want you to know about. So when I talk about buprenorphine, I may also use the market name Suboxone. That's one of the big ones, which I have pictured here. Suboxone is a combination buprenorphine and naloxone. The naloxone remains inert. Within the medication, and it is a deterrent so that somebody could not potentially inject it. Naloxone is the overdose reversal agent that we'll speak about more. So buprenorphine reduces cravings and withdrawal symptoms. It really has pretty limited side effects when you put it side by side with the illicit drug use, and it does not have very many contraindications. Pregnancy can be one, but there are options such as Subutex, which is monotherapy, or still to today, the evidence indicates that methadone is the best method for opioid replacement for pregnant women. So there's less potential here compared to methadone, again, because it's not the full activator of the receptors. But there are some benefits that we'll talk about with methadone about you likely not getting access to all that much medicine at one time due to some of the restrictions. So buprenorphine, it does have to be dispensed by a licensed trained physician. It can be carried out in specialty clinics such as OTPs or OBOTs, but it can be prescribed by anybody who has a medical license. Up until last year, there was a requirement for something called an X waiver. This was a special endorsement on a medical provider's license to be able to do it. They did away with that requirement, though simultaneously with the removal of that requirement, they remained a training component, which is required for any prescriber. Some look at that as a bit of a red tape deterrent, but it's still better than it was a year ago. So we'll take that as a win. Buprenorphine and fentanyl, I'm not going to read this whole slide. Here's the takeaway. if you have buprenorphine in your system and you are exposed to fentanyl, you have a better chance of survival because that buprenorphine will give you an insulating effect from that central nervous system depression. And so having it available out there in the world among people who may continue to use is still a positive. So that's takeaway. It doesn't have to be all or nothing in this world. That's the point. We want to have these medications out there and available. People get worried about the misuse of buprenorphine. I'm not going to lie to you and say it does not happen, but the research does tell us that it is much, much less than what it possibly could be. Meaning what the illicit use is and what the potential could be with how much supply there is out there. So I take these as pretty optimistic figures. And what we know from several studies coming out of COVID, where we had expanded access through things like telehealth, is that we did not see a drastic increase in adverse results from more of this medication being out there in the world. So that is, again, a positive. So some issues, there's a lot of demand. There's still not necessarily a lot of supply, and I'll speak about that on the next slide a little bit. I told you some of the red tape is gone. There's still a reluctance among some prescribers to use this medication with a great deal of frequency. It can have some geographical barriers, depending on what kind of communities, mainly rural areas, are harder hit, where they have supply issues. It is expensive. All these medications are expensive to a degree. Methadone being one of the more cost-effective manners. I do see the hand up. I'm going to keep going for a second. I will get to you. I promise I'll give time. We do have non-compliance, misuse, and diversion issues. So as I said, I'm not going to lie to you about that, but it is less than the alternative. And there is a bias where people still look at this as you're just trading one drug for another, which please understand that that's not how medication works. It is a very different situation to go from buying a drug from a street level dealer and that level of secrecy and danger to being able to go into a Walgreens and buy your medication, taking it as prescribed and regaining a stability. It is still an opioid. So there is still that, but if done in a proper monitoring manner, I would rather have them on that medication and alive than getting something in their drug supply that causes them to die immediately. As I said, there are supplies. The study found recently that about 20% of pharmacies do not provide buprenorphine. Often these are self-established regulations. Sometimes they have quotas. Sometimes they just don't want to touch it. There are some reasons why. You can Google this, stories about usually mom and pop pharmacies that get like raided by the DEA because they might be filling a lot of prescriptions for the monotherapy versus the Suboxone. Monotherapy is a lot easier to divert and misuse because it does not have that naloxone in it. So that is a red flag for the DEA. Also, if you're filling a lot of out-of-state prescriptions. But here's the rub of that. We have a lot of people who live in rural areas that might have to go across a state line because that's where their local pharmacy is. Yeah, it's weird to have to go into Kentucky from Tennessee, but if that's your closest Walgreens, that's how it is. But that alerts the DEA and they freak out about that kind of stuff. And so pharmacies sometimes just don't have an appetite for that kind of stuff. I get it on one hand, but again, where's the political will? We need to make some changes. Here's a really solid update. I've talked to you before about things like Sublocade, which is a depot injection, intramuscular, and it's great because it is a once a month injection that slowly releases the medicine. So all this diversion stuff I'm talking about goes out the window. We give them the injection once a month, easy peasy. They don't have to do anything. They don't have to worry about taking a medication every day. We're not putting this stuff on the street. There's a new product that was approved as of May 2023. It's called Brixaldi. It also is available in weekly administration. Why would you want to do weekly? Well, that can make for better adherence to the treatment protocols, because sometimes if you give somebody an injection once a month, you might not see them ever again because that's too long between appointments. Once a week, though, keeps a kind of a tighter rope on it while they're demonstrating that treatment adherence. And it also, compared to Sublocade, has advantages for where you inject the medicine. You can inject this one in the upper arm, whereas Sublocade you have to inject into the abdomen. That can be a bit of a turnoff for some people because it's a pretty big gauge needle and it does not feel good. But hey, once a month not feeling good and you're not going to overdose and die, I think it's a pretty good trade-off. We know that patient satisfaction for these depot medications is better than oral medications, so I expect more and more players on the market as time goes on. These are not the most inexpensive products, however. There are options with coupons and things like that, but it does create some restrictions. More costly, a more cost-effective option for many is what's been around since really heavy in the 70s, but it's been around even before that, methadone. And there's a lot of stigmatization around methadone. Some people just don't even like the words, but methadone is a really wonderful medication. And it's the most researched of all of our MOUD medications and used kind of in a lot of different research areas with incarcerated individuals as well as those who are not. So we know a lot about it and how it can be effective. So again, same things. It's going to reduce risk of overdoses, reduce relapse on other illicit substances. And if we can demonstrate adherence to it, we tend to have better results for overall health in general. Disadvantages: it is a full agonist, so full activator, which means someone's tolerance will go up. That's why you tend to see people have to ratchet up their doses. They don't stay on a steady dose for a long time, and what the downside of that is for somebody on long-term methadone maintenance, they can get to a very, very high dose where there are actually legal restrictions around how much that dosing can be before it requires some override waivers that the doctor has to do. And then pulling people back from that is a very time-consuming, taxing process. Withdrawing from methadone is incredibly uncomfortable, even compared to things like heroin. So there's a lot of fear about it for somebody who's a long-term recipient of this medication. It can result in overdose if you take enough. As I said, it does not have any of those insulating sealing effects that I mentioned with buprenorphine. Now, we did see some increased access with telehealth, where there was some more opportunities for take-home prescriptions, because many times this has to be dispensed at a clinic. That can often be a daily ordeal for people. Once they get established, it can ratchet down to weekly, or even allowing take-home medications that will vary by state. But anyway, so we saw emergency expansion because during COVID, people couldn't go to the clinic every day, especially early on during that the pandemic. So increased availability, and it did not seem to result in any adverse reactions for folks. So that is a good thing. I want to talk about Vivitrol, and then I'm going to have to close out. So Vivitrol is naltrexone. It is the blocker. It is a great medication. Still, many prescribers are not aware of it. It is expensive, just like with Sublocade. But again, there are coupons and options and different ways of accessing the medication. Because it's not an opioid, you lose some of that stigma around it, and so some patients gravitate towards this, especially. And by the way, Vivitrol is naltrexone. If I did not say that, because it also comes in oral form. Vivitrol is the injectable form. So this carries less stigma with it, and for some people, they may be in situations where they cannot take methadone or buprenorphine because of restrictions from the outside world, such as employers or legal systems. There's not a great deal of appetite for somebody continuing to test positive for an opioid, even if it's a medication. And I do get that in certain situations. We work with pilots, airlines, railroad workers, very safety sensitive jobs where you may not be able to tell a difference between somebody who's taking their legitimate prescription versus diverting off the street. But that for those folks, naltrexone, this medication may be a very, very good option. It provides a safety net, as I described. It's not a silver bullet, but it is better than nothing. And that's my point I want to leave you with medication. Medication is the evidence-based, effective medication protocol for dealing with opioid use disorder. To deny medication is, in my opinion, unethical, and based on the situation we're in now, immoral, because that is what is driving so much of our overdose in this country is people who, for whatever reason, cannot get access to the proper tools. So I know some of you have had to jump off. I have always more I could tell you, certainly, but I do want to pause and give a moment for questions if there are any.
I do not see anything in chat.
Okay.
All right.
Someone has privately chatted me. How common is opioid use disorder in pilots, etc. It's as with everything. Everybody is at risk. So just based on profession, people are at no lesser risk than any other person. So that's why Bradford Health Services, and I put our information up here on the screen, that's why we have programs that are specifically work with those in the transportation industry. At Warrior, which is what you see pictured here, we have a healthcare professionals program where we treat the most number of physicians in the Southeast. So we have a lot of doctors, we have a lot of nurses and other professionals who need treatment and access to these medications.
Perfect. Thank you so much. You are a wealth of information, Zach. We get so much out of this every time you join us. So thank you so much for taking the time.
Thank you.
Thank you to Bradford rather for sponsoring today and making it possible. And just to let you know, next week we are back with a presentation about maternal mental health, helping your pregnant and postpartum employees. And then coming up on the 18th, for those of you that may have attended the mindfulness session that we did in the fall, Teresa will be back doing an extended version of that. It'll be an hour and a half on the 18th. And registration is open for that now. Again, thank you so much, Zach, for coming and joining us. We always enjoy so much having you with us. And we look forward to having another opportunity to have you come and speak to us.
I would love it. Thank you very much to all. Have a good weekend.